Alright, so now we'll be discussing the development of the sinus venosus. So as we all know, when we study the internal structure of the right atrium, we encounter two portions. We say there is a trabeculated portion of the right atrium, and we say there is a smooth portion of the right atrium. So the smooth portion of the right atrium is also known as sinus venosus. And there is a very characteristic demarcation line between the trabeculated and the smooth portion of the right atrium, and that is crista terminalis. The differentiation between the trabeculated and the smooth portion. So the sinus venosus is nothing but is basically the incorporation of the sinus horn, the venous drainage portion, the incorporating sinus horn. And the trabeculated part of the right atrium is again formed from the common atrium. Viewing this dorsally, so here is the right hand side and there is the left hand side. This is the atrium and this is the sinoatrial junction between the atrium and the sinus horns. So this is the right sinus horn and this is the left sinus horn. So one sinus horn is made up of three draining veins. That is, we have the umbilical veins, we have the vitelline veins, and then we have the common cardinal veins. Common cardinal vein is further receiving drainage from the anterior cardinal vein and the posterior cardinal vein. So what happens is this sinoatrial junction, it shifts to the right. There is a shifting of the sinoatrial junction towards the right in favor of where the blood is coming from, that is the right side. By the 5th week of development, the right umbilical vein and the left vitelline vein degenerates. As the left vitelline vein degenerates, so what happens is, if this is the left vitelline vein, if it degenerates, so what shall happen is this left sinus horn loses importance. And we have more importance for the right sinus horn, which was also facilitated by the left to right shunts of blood, which was occurring in the 4th to 5th week of development. Then by the 10th week of development, we have obliteration of the left common cardinal vein. And finally, what remains of the left sinus horn shall get converted into the coronary sinus, into which drainage of the great cardiac vein, the middle cardiac vein, and the small cardiac vein. And then we have another oblique vein of left atrium. So that is basically the remnant of the left sinus horn, and the left umbilical vein shall get converted into the ligamentum teres that is present in the liver. As the right sinus horn gains importance, as the atrium starts to grow, now it has grown till here, so it will incorporate this portion of the right sinus horn. As this incorporates this portion of the right sinus horn, what we shall get is this portion is the right sinus horn, and when it gets incorporated, it gets converted into smooth structure known as sinus venosum. And when it is opening, the sinoatrial orifice, this is again the sinoatrial orifice which has shifted towards the right. So it has two valves. It has a right venous valve and it has a left venous valve. Now these two venous valves, the right and the left venous valve, fuse dorsocranially, like these will fuse dorsocranially to form a septum known as septum spurium. The remaining portion of the venous valve, the remaining portion of the left venous valve, along with the septum spurium, as we will see later on, if we draw this to be the common atria, right, and we are incorporating the sinus venosum, this is the septum spurium, and this will be the developing septum primum. So what we shall get is that the left venous valve along with the septum spurium will fuse with the septum primum, and this right venous valve shall give rise to valve of the IVC and valve of the coronary sinus. Finally, we get this scenario. This portion of the atria gets integrated. This is the sinus venosum, and this dividing line between the trabeculated portion of the right atrium, which has the musculi pectinati, and the sinus venosum is known as the crista terminalis, which is represented on the external surface of the heart as sulcus terminalis. So we are proceeding into another section of heart development, that is the septum formation. In reality, there are basically two mechanisms through which septum formation can occur. There is the mechanism of endocardial cushions, and there is just the sheer approximation of two tissues that basically contributes to the formation of the different septa in a body. So first we will discuss the endocardial cushions. Endocardial cushions are just a protrusion of the endocardium which eventually gets populated with cells, and this ECM gets deposited in here. In the heart, the membranous part of the interventricular septa, which is derived from the conotruncal ridges. Then we have the atrial septa that forms between the two atria, dividing the common atrium into left and right atrium. And ultimately, by formation of the spiral or the conotruncal septum, we have the formation of the aortic and pulmonary channel. The next pathway or the next mechanism by which septum formation occurs is basically due to expansion of two structures approximated, and ultimately results in the formation of the septa. So this happens in the muscular portion of the interventricular septa. As we know, the interventricular septa is composed of two portions. We have the membranous portion of the interventricular septa, which is formed by the endocardial cushions, and we have the muscular portion of the interventricular septa, which is formed by two actively growing ridges which get approximated in the middle. So before proceeding into the formation of the ventricular septum, we need to cover one last thing, and that is the formation of the pulmonary vein. As we have seen, and as we incorporated the sinus venosum into the right atrium, we should get one thing clear, and that is the left atrium will also incorporate some of the portion of the pulmonary vein. What happens is the pulmonary vein is formed by the caudal portion, like as we studied that if this is the heart tube, so the heart tube was attached to the dorsal portion of the pericardial cavity by a dorsal mesocardium. So the dorsal mesocardium, its central portion breaks down, and we ultimately just get a small piece of it at the caudal portion. So what happens is the mesenchyme at the caudal end, that is the caudal border of the dorsal mesocardium, it develops into something known as a dorsal mesenchymal protrusion. At the atrial pole of the dorsal mesocardium, when we didn't do the cardiac loop, right, when it was still in the primordial state, at the atrial end or the caudal end of the dorsal mesocardium, we have a mesenchymal protrusion known as a dorsal mesenchymal protrusion. So at this atrial pole, the pulmonary veins form within the mesenchyme of this dorsal mesenchymal protrusion. And ultimately what happens is, initially we have one main branch of the pulmonary vein which gives two branches to each lung. Initially we have that when the dorsal mesenchymal protrusion has just invaded the left atrium, we will have just one opening, and that opening will be of the main stem. But as the atria expands, it will incorporate all the four branches, that is two to each lung. It will incorporate all the four branches of the pulmonary vein within itself, and it will form again a smooth portion of the left atrium that is formed by the dorsal mesenchymal protrusion derived from the dorsal mesocardium. So here we have the trabeculated end, here we have a trabeculated end. This trabeculated end is the primitive atrium, whereas the sinus venorum is derived from the right sinus horn. And same goes for this smooth portion of the incorporated pulmonary veins, and this is derived from the dorsal mesenchymal protrusion, which was a mesenchymal collection of cells at the caudal border of the dorsal mesocardium. So now let's proceed into the septum formation in the ventricles and the ultimate formation of the AV canals, that is the atrioventricular canals. Right. So at the level of the AV canal or the orifice that connects the atria and the ventricles, we have four endocardial cushions. We call them the AV cushions. We have the dorsal superior AV cushion, we have the ventral inferior AV cushion, we have the right AV cushion, and we have the left AV cushion. Now what happens is that the dorsal superior AV cushion will fuse with the ventral AV cushion, and what we shall get is the formation of a right and a left atrioventricular canal. So we are getting separation of the AV canals, so we get two AV canals now. So that is done, but the thing is, initially the AV canal only gives access to the primitive LV, that is not to the right ventricle, and is separated from the bulbus cordis by the bulboventricular flange. So what I mean by that is, initially that these two AV canals open just into the left ventricle. There is no connection of the right ventricle, right atrium with the right ventricle. To surpass that, what happens is that this posterior extremity of this canal will sideline with the dorsal endocardial cushion, and it will become less prominent than before. So what we'll get is, we will get a sort of midline shift. We will get a midline shift of this flange to right here, so that we get the formation of two AV canals which open into their respective ventricles. The last portion of the formation of the ventricular septum is, as we did before, we have different ways of forming a septum, and one of them was by increasing size of the two chambers. As the sizes will increase, this medial portion, it joins and approximates with the other, form the muscular interventricular septum here. So this is formed by the conotruncal ridges by the way of endocardial cushions. Conotruncal ridges. As the formation of the AV canals finishes at the AV orifice, we have the formation of a dense mesenchymal tissue which will undergo fibrosis to form primordial muscular cords, which will ultimately develop into atrioventricular canals, and it will develop into the papillary muscles. So to conclude the discussion of the embryology of the heart, and then later on move on to the congenital heart defects, we will not be covering the vascular system here. We will cover it in the further videos. So now we will discuss something known as the conotruncal septum or the spiral septum. The function of this conotruncal septum is to divide the aorta and the pulmonary artery into separate channels from the common outflow tract, that is the truncus arteriosus and the conus cordis. To resolve that, we have four swellings at the level of the truncus arteriosus and the conus cordis. For the formation of the conotruncal septum, we have a right superior truncus swelling, we have a right dorsal conus swelling, we have a left ventral conus swelling, and we have a left inferior truncus swelling. Now what happens is, the right superior truncus swelling, which we will represent with red, it basically starts growing towards the left like this, and the left inferior truncus swelling will go posterior to this left superior truncus swelling, and it will do the same way. So what we are doing is, they have followed a spiral path. They have wound around each other, right? And then the right dorsal conus swelling and the left ventral conus swelling, they will also meet midway, right, to form something that looks like this. We have divided this tract into two portions. We shall get an anterolateral portion, an anterolateral pathway that will form the outflow tract of the right ventricle. Then we have a posteromedial portion, and basically that will form the outflow tract of the left ventricle. As we can see here, we have these swellings. They will grow like this, in a spiral setting. And ultimately, we have the approximation of the conus swellings as well. And just one last thing, the membranous part of the interventricular septum is also being formed by these conotruncal ridges. This endocardial cushion that is being formed right here in these portions, when we are considering one endocardial cushions, so the cells that is in these endocardial cushions, they are neural crest cells. So what are neural crest cells? We have, these are the neural folds which will grow towards each other. So when they grow towards each other, and this ultimately forms the neural plate right here. So what will happen is some of these cells from right here will break off. These cells are not supposed to form the neural plate. They will break off at this level. And the reason behind this is the intermediate levels of bone morphogenic factor, which we will cover in a future video. So how does that occur? So we have intermediate BMP that is at the NCC level. NCC will break down and they will form the neural crest cells. Neural crest cells basically form part of the facial skeleton, right? So we have connective tissue and bones of the face and the skull, they will form that, and the neural crest cell will also form the conotruncal septum. So what happens is, usually when we have someone who is born with a congenital facial abnormality, it is expected that he will also show a heart abnormality, because the reason being that the neural crest cells are being shared. If you have a facial abnormality, it is possible that neural crest cells might have gone disarrayed.